Welcome back, guys. Now in this video, let's discuss about high altitude physiology or high altitude acclimatization. Okay, what exactly happens when you ascend up to high altitudes? Will there be any change? Will there be more oxygen or will there be less oxygen? So how your body is going to adjust itself, how your body is going to acclimatize itself to such variations in the high altitudes that we are going to discuss in this video. First 15 minutes I will be discussing about what is normal atmospheric pressure, what is the partial pressure of oxygen in the atmosphere when it is at the sea level, and I will be discussing about the partial pressure of oxygen in the alveolus. Okay, I will be discussing things which are normal in the beginning. Later I will discuss how it will change. Okay, what are the changes that you are going to see, okay, in the high altitudes, right? So having said that, now let's begin the topic. High altitude physiology. Okay, high altitude physiology. Now, first question. See, if this is the earth, for example, let's say this is the earth. Earth is surrounded by what? Earth is surrounded by environment. Okay, there is environment around the earth. Now, this environment, it is composed of different gases. Okay, there are different gases. See, these gases, they are going to exert the pressure, right? All these gases, they are going to exert the pressure. Okay, so there is some atmospheric pressure. There is atmosphere or the environment. Now this atmosphere is going to exert the pressure. Okay, so that is called as atmospheric pressure. Okay, atmospheric pressure. And how much is that value? 760 mmHg. Okay, the atmospheric pressure is 760 mmHg. Okay, now why exactly is this pressure, atmospheric pressure? Why? It's because in the environment there is nitrogen, there is oxygen, and there are other, like, minor gases like carbon dioxide, helium, like, other gases are also there. Okay, but nitrogen composition is 79%. Oxygen composition is how much? 21%. Okay, so this is the composition of atmospheric air. So in the atmospheric air, there is 79% of the nitrogen and 21% of the oxygen is present. Okay, this is something normal. Now I am talking about the partial pressure, the concept of partial pressure. Partial pressure. Now what is this partial pressure? See, all the gases together, okay, all nitrogen and oxygen and other minor gases all together, they are exerting how much pressure? They are exerting a pressure of 760 mmHg. Now I am talking about the partial pressure. Means partial pressure is a pressure exerted by an individual gas. Okay, let me write here. It's a pressure exerted by an individual gas. Okay, individual gas. For example, let me talk about the partial pressure of oxygen. Okay, the partial pressure of oxygen in the atmospheric air. Now, what is the atmospheric pressure? It is 760 into how much is the oxygen fraction in the environment? It is 79%. Okay, sorry, 21%. If you convert it into fraction, okay, if you convert it to fractional concentration of oxygen, FiO2, fractional concentration of oxygen, that will be 0.21. Okay, so 760 into 0.21. How much? What is the partial pressure of oxygen in the environment? It is 160 mmHg. Okay, so all the gases together, they are exerting a pressure of 760 mmHg. Out of the 760 mmHg, okay, out of the 760 mmHg, 160 mmHg is because of oxygen. Okay, oxygen is taking this much. Okay, 160 mmHg is because of the partial pressure of oxygen. For example, let's say if 160 is because of oxygen, means remaining 600, right? 600 mmHg. The 600 mmHg is because of which major gas? It is nitrogen, partial pressure of nitrogen. Okay, that is, you can say 760 into 79, 0.79. Okay, so 600. So this is the concept of partial pressure. So oxygen is exerting how much pressure? 160 mmHg, and that's the point which I want you to know. Now you are inspiring, okay, you are inspiring this oxygen. Okay, now let me show you. Now you have taken this air, okay, into your respiratory tract. Now when you take this air into your respiratory tract, now what happens is there will be water vapor in the paranasal sinuses. First the air is going into the paranasal sinuses. There the air will be humidified. There will be water vapor. There the air will be humidified. So now what happened to the partial pressure of oxygen in inspired air? In inspired air, the partial pressure becomes from 160, it becomes 150 mmHg. Okay, 150 mmHg. Okay, if you want to know the formula, there is also a formula. The partial pressure, it is calculated by partial pressure of oxygen or any gas. It is calculated by atmospheric pressure minus water vapor pressure. Okay, atmospheric pressure minus water vapor pressure into fractional concentration of that particular gas. Here I am talking about oxygen, so 0.21. So what is the atmospheric pressure? I have told you 760 mmHg minus water vapor pressure is constant 47 mmHg. Water vapor pressure is 47 mmHg into 0.21. So if you do this, okay, if you do this, definitely the answer is going to be 150 mmHg. So what I am trying to put into your mind is, in the environment, the partial pressure of oxygen is 160 mmHg. But the once it enters into your airway, okay, because of the humidification process, because of the presence of water vapor, the water vapor is going to dilute. Okay, some oxygen will be dissolved in the water vapor. So oxygen is getting little diluted. So oxygen concentration becomes 150 mmHg. Okay, 150 mmHg. Now here, see, now the air is going through the respiratory tract, trachea, bronchi, bronchioles, something like that. Now this air is coming, or the oxygen is coming into the alveolus. Now partial pressure of oxygen in the alveolus, how much it will become is 104 mmHg. Okay, 104 mmHg, and this is something normal. Okay, so the point is, in the environment it is 160 mmHg. In the inspired air it is 150 mmHg, and in the alveolus, by the time it comes to the alveolus, the partial pressure of oxygen in the alveolus is 104 mmHg. Okay. Now look, who is coming here? Okay, the pulmonary arteries, they are carrying this deoxygenated blood. Okay, so the pulmonary arteries, and they are dividing into pulmonary capillaries anyway. See, now here in this venous blood, the venous blood is coming. Okay, pulmonary arteries are carrying the venous blood. You already know it. Pulmonary arteries carries venous blood. Okay, now this venous blood is coming to the lungs for the purpose of oxygenation. Now look, what is the partial pressure of oxygen? What is the partial pressure of oxygen in this venous blood? In this venous blood, it is 40 mmHg. 40 mmHg. So look here. Here there is high partial pressure of oxygen. The partial pressure of oxygen is 104 mmHg in the alveolus. What is the partial pressure of oxygen in this venous blood? It is 40 mmHg. So there is a gradient. So oxygen will diffuse from high partial pressure to low partial pressure easily. You know, the gases are undergoing diffusion. The gases will move from high partial pressure to low partial pressure. So in our lungs, the gases are getting diffused. The oxygen is getting diffused into the blood vessels. So the blood is getting oxygenated. Okay, the blood is getting oxygenated. This is something normal. Okay, this is how the gases will go. This is how the oxygen will go into our blood, because from high partial pressure to low partial pressure. Now what happens when you go to high altitudes? Now let's begin the topic. Okay, now in high altitudes, what happens? Okay, see, in high altitudes, the barometric pressure, okay, barometric pressure, in a simple way you can say atmospheric pressure, decreases. Okay, the atmospheric pressure, what's going to happen? The atmospheric pressure is going to decrease. Means as you are ascending up, it's very simple. It's very simple. See, now try to understand, guys. Here is the earth. Imagine here is the earth. Okay. Now this is the level of the sea level. Okay, land at the sea level. Now look, here you are having what? There is atmosphere. Okay, atmosphere is there. Now all this atmosphere, okay, all this atmosphere is exerting pressure on you. It's exerting pressure on the land. It's exerting pressure everywhere. Okay, but when you are going up, when you are ascending up, what happens? The pressure automatically decreases, because now as you move up, this part, okay, this part of atmosphere is not there. It's not exerting pressure on you. Only, for example, say you are standing here. For example, you went to this much height. Now only this much pressure will be there. Little pressure. Okay. Even I can give you one more example. For example, you have taken a dive into the ocean. Okay, you have taken a dive into the ocean. As you go deep down into the ocean, the pressure will increase. The pressure on your body increases. The water pressure on your body increases. As you ascend up, as you are again coming back to the surface level, the pressure decreases. Okay, so in high altitudes, the more you go up, the more you ascend up, the barometric pressure increases. But the composition of gases, look, composition of gases, even there, gases will be there, oxygen will be there, environment, even it's present there. Okay, composition is same. Okay, composition remains same. That is, even there, if you check the nitrogen composition, nitrogen amount, the amount of nitrogen, it will be 79%. Oxygen, it will be 21%. Okay, 21%. Composition is same, but their pressures will decrease. For example, let's put it this way. If you ascend up, okay, we say usually for every 5,000 meters, okay, for every 5,000 meters, the atmospheric pressure drops by, okay, atmospheric pressure drops by half. Okay, by half. Means for every 5,000 meters, every 5,000 meters you go up, atmospheric pressure will become half. Means from the sea level, here the atmospheric pressure is 760. If I go up 5,000 meters, the atmospheric pressure will become half. Means 760 divided by, okay, something like that. Okay. So look, there are many people, okay, they have the habit of climbing the huge, like, mountains. Like for example, let's say Mount Everest. You are planning to go to the Mount Everest. When you are climbing up, okay, Mount Everest is going to be at a height of 29,000 feet. 29,000 feet are 8,850 meters. Okay, 8,850 meters. Now, what happens at there? Okay, Mount Everest. Okay, the atmospheric pressure, okay, the barometric pressure at that area is going to be 250. You want to be precise, 253 mmHg. See, normally here at the sea level, the atmospheric pressure is 760 mmHg. But at the Mount Everest, what is the partial pressure? No, not partial pressure. What is the environmental pressure or the atmospheric pressure? It is just 253 mmHg. Now let's calculate the partial pressure of oxygen. Now here at the sea level, the partial pressure of oxygen is 160 mmHg. We have calculated. Okay, it is 160 mmHg, the partial pressure of oxygen at the sea level. But what is the partial pressure of oxygen at the Mount Everest level? Okay, at high altitudes. So partial pressure What is the formula for the partial pressure calculation? Atmospheric pressure, that is 253 into how much oxygen is there? How much? 0.21. 0.21. If you do the calculation, it will be somewhere around 53.13. So this is the partial pressure of oxygen in the high altitudes. Okay, 53.13. Here it is 160. But there at the Mount Everest, the partial pressure is decreasing. And you know what happens? Now, when it enters into your body, okay, when it enters into your respiratory tract, humidification will occur. So what happened to the partial pressure of oxygen in the inspired air? The partial pressure of oxygen in the inspired air, actually, it becomes 43 mmHg. Okay, I'm just giving the direct values. I'm not going into the calculations. 43 mmHg, decreasing. And if you calculate the partial pressure of oxygen in the alveolus, okay, partial pressure of oxygen in the alveolus, it's further reducing to 40 mmHg. Okay, so what I'm trying to put into your mind is when you ascend up to the high altitudes, but the partial pressure of gases, see, the partial pressure of oxygen is decreasing. Okay, partial pressure is decreasing. We know gases will move from high partial pressure to low partial pressure, but in high altitudes there is no partial pressure. Partial pressure is going to be very less. So the amount of oxygen that you get, okay, the amount of oxygen that you are getting with this diffusion is going to be very, very less. So you are getting very less oxygen in the high altitudes. Okay, so that's why, okay, you will be getting hypoxia. Okay, so the patient is going to develop hypoxia. This is the problem in the high altitudes. Okay, the patient or the person who is ascending high altitudes will suffer with hypoxia. Okay, now what I want you to know here is, in this topic, how this patient is going to get acclimatized to this. Okay, your body will acclimatize to these high altitudes. Your body prepares certain mechanisms. Your body is going to adapt by doing certain mechanisms, okay, to get the enough oxygen. So what your body is going to do, that we'll discuss now. Your body is going to acclimatize. Acclimatization. What your body is going to do with this acclimatization? How? Okay. See, first thing, to get the enough amount of oxygen, okay, your respiratory rate increases and the tidal volume also increases. That means the amount of air that you take with every breath, tidal volume. The tidal volume is going to increase and the number of times you breathe. Okay, usually we breathe, for example, like 12 to 16 times in a minute. But when you go to high altitudes, to get the enough amount of oxygen, you are getting hypoxia. Okay, to get the enough amount of oxygen, you are going to breathe more number of times and with more depth. More number of times and with more depth. That is called as hyperventilation. And that's the MCQ. So, a person who is on high altitudes is going to do the hyperventilation. Okay, hyperventilation is the first thing. Not only that, to get the enough amount of oxygen delivering to the tissues, you have to increase the number of these catchers, oxygen catchers. Who catch the oxygen? It's the hemoglobin. Where is this hemoglobin present? RBCs. So you increase the number of, when you go to the high altitudes, you increase the number of RBCs. Okay, you increase the number of hemoglobin, RBC and hemoglobin. Okay, so how this is going to occur is with the help of erythropoietin. So whenever you go to high altitudes, your kidneys are going to produce, okay, your kidneys are going to produce erythropoietin. So peritubular capillary cells, are, to be precise, interstitial cells of, okay, interstitial cells of peritubular capillaries are going to produce this erythropoietin immediately. Okay, when you go to high altitudes, immediately erythropoietin is going to be produced within hours, and that erythropoietin will stimulate the production of RBCs. Even though it takes days for the production of RBCs, it takes almost 5-6 days. But this erythropoietin is increasing the number of RBCs. So when you are living on the high altitudes, okay, you have decided to live on the high altitudes in high terrains. So the RBC count in you when compared to me is going to be more, because more RBCs means more hemoglobin is going to catch more oxygen. Okay. Next, what else will happen is there will be, okay, increase in the diffusion capacity at the level of lungs. The first two are more important. Now, at the level of lungs, there will be more diffusion happening, more diffusion of gases happening. Why there will be more diffusion? How more diffusion can occur? Because you are breathing more number of times. See, You are breathing more number of times, more oxygen will go into your lungs. At the same time, to get that oxygen, you have to send more blood also. You have to send more and more blood to the lungs. Okay, you have to send more and more blood to the lungs, so that more blood is going, so more diffusion will occur. More blood is going, more hemoglobin is going. So readily the gases will be uptaken. Okay, so there will be increase in the diffusion capacity of the lungs, because there will be increase blood flow to, okay, increase in the blood flow to catch oxygen. Okay, this is a point which I want you to. Now the blood flow to the lungs increases, so diffusion of the gases will also increase. Diffusion of the gases is also increasing. Now, what else? Who requires this oxygen? Tell me. At the end of the day, who requires this oxygen? The oxygen will be needed by the tissues. Okay. So which blood vessels are going into the tissues? Tell me. To supply the blood, which blood vessels are going into the tissues? Capillaries. Okay. So more the number of capillaries means more blood flow into the tissues. More blood flow means more oxygen will be delivered to the tissues. Okay. So now what your tissues will do is, tissues are going to increase the number of capillaries. Increase the capillaries. Okay. Increase capillaries. Means more number of capillaries are going to come into the tissues. That's called as the angiogenesis. Okay, this is called as what? Angiogenesis. So this angiogenesis will be seen with hypoxia. Okay, hypoxia living in high altitude. The patient, the capillary density at the level of tissues, the capillary density at the level of tissues is going to be more. Okay, because in these patients, the hypoxia, okay, hypoxia is going to stimulate certain genes. The hypoxia is going to stimulate certain genes called as hypoxia inducible factors. Okay, now stimulation of this hypoxia inducible factors, these are the transcription factors actually. Okay, these are the transcription factors. Now once these transcription factors are activated, now they will go and stimulate the genes like vascular endothelial growth factor related genes. So this vascular endothelial growth factor will be produced. Now this vascular, in the name itself is there, vascular endothelial growth factor, which helps in the development of the new blood vessels in the capillaries. So more capillaries means more blood will be going to the tissue, so more oxygen will be supplied to the tissue. Okay, so what and all seen? So if a patient, let's say something like this, a person who is living on the high altitudes is going to get acclimatized to the high altitude environment by doing the hyperventilation. This person is going to do the hyperventilation when compared to the normal person. His RBC count is going to be more, his hemoglobin levels are going to be more, his diffusion capacity is more than yours and mine. His diffusion capacity is more because he is breathing more number of times, he is sending more amount of blood to his lungs, so more diffusion of gases is happening. So in an attempt to get more oxygen, and the capillary density at the level of tissues is also going to be more. Okay, and not only that, if you check in this person, the amount of mitochondria in their cell, okay, at the cellular level, the amount of mitochondria which uses the oxygen, okay, now you have to get as much amount of oxygen as possible because already you are getting very less oxygen. So to get as much amount of oxygen as possible, their mitochondria level, okay, their mitochondria levels are also going to be more number of mitochondria in their cells or tissues. Okay, so these are the points which I want you to know. Now let's see how this hyperventilation is going to occur. Okay, now let's see some important points how this hyperventilation is going to occur. Okay, now you went to high altitudes. Let's write something like this. You went to high altitudes. Now tell me, whenever you went to high altitude, okay, what happened to the partial pressure of oxygen? The partial pressure of oxygen decreases. So you are getting more oxygen or less oxygen? You are getting less oxygen. So definitely you are going to get hypoxia, hypoxia. Okay, hypoxia. You are getting hypoxia. Now, you tell me, there are two types of receptors in your body. Okay, there are peripheral chemoreceptors and central chemoreceptors. Peripheral chemoreceptors always check. Peripheral chemoreceptors always check the amount of carbon dioxide levels in your blood. Okay, they will always check how much carbon dioxide is there. Okay, how much acids are there? So peripheral chemoreceptors are sensitive to carbon dioxide and acids. Okay, sorry, not peripheral. Just I want to make a change here. It's not peripheral. Sorry, it's a central. Okay, central chemoreceptors. Please make a change. So central chemoreceptors are highly sensitive to the level of carbon dioxide and acids. Now, peripheral chemoreceptors. Peripheral chemoreceptors. Now, these peripheral chemoreceptors, where they are present? They are present in the aorta and carotid sinus. Okay, aorta and carotid body, you can say. Okay, so in these areas, there are chemoreceptors present. Aorta and carotid body, there are chemoreceptors present. They always check. Okay, they always check the levels of oxygen. Okay, partial pressure of oxygen, enough oxygen is there or not. They are always concerned about the oxygen levels. So here I am telling you important points. Look, the central chemoreceptors which are present in the brain. Okay, they are present in the brain. They are checking which levels? They are checking carbon dioxide levels. And the peripheral chemoreceptors, look, the peripheral chemoreceptors, okay, which are present in the aorta and carotid body, they are sensitive to oxygen levels. Now tell me, whenever there is hypoxia, now the patient is having hypoxia. Now tell me, which receptors will be activated? Peripheral chemoreceptors. Peripheral chemoreceptors are activated. Now, you know, once the peripheral chemoreceptors are activated, the activation of peripheral chemoreceptors are going to cause hyperventilation. Okay, so hyperventilation is going to occur. Means you will breathe more number of times and with more depth. The depth as well as the frequency, both are increasing. Means you will breathe more number of times to get enough oxygen, to catch more oxygen from the environment. Okay, to catch more new oxygen from the environment. So there will be hyperventilation. But the problem with this hyperventilation is, look, okay, initially there will be hyperventilation. The person is breathing more number of times. Okay, hyperventilation. But the problem with this hyperventilation is, when you are doing hyperventilation, see, inspiration, expiration, inspiration, expiration, you are getting more oxygen. At the same time, you are excreting more amount of carbon dioxide. Okay, there is carbon dioxide washed out. So more carbon dioxide will be washed out of your body. You know, carbon dioxide is the source of acid in the body. Carbon dioxide is the source of acid in the body. As you are removing the carbon dioxide, you will decrease the acid production in the body. You know, carbon dioxide reacts with the water, produces the carbonic acid. Okay, and produces the H plus ions, protons. But as you are removing the carbon dioxide out of the body, so what happened to the acid levels? Acid levels decreases. Okay, acid level decreases. When the acid levels in your body decrease, means when the acid levels in your blood decreases, means that will cause alkalosis. Now the patient ends up in the alkalosis. Now this alkalosis, okay, this pH imbalance, this alkalosis is due to the respiration. Okay, now the patient is doing the hyperventilation. Whenever the patient does the hyperventilation, there will be carbon dioxide washout, and the carbon dioxide washout is going to cause the alkalosis. So it's a respiratory thing, right? So this is called as respiratory. Okay, this is called as respiratory alkalosis. Now tell me, a patient or a person who is living on the high altitudes, they are going to do the hyperventilation. Not only that, these patients are going to have respiratory alkalosis. Okay. Now, look here carefully. This respiratory alkalosis, what it will do? See, acidosis is the stimulus. Okay, acidosis is the stimulus for the central chemoreceptors. Okay, acidosis is the stimulus for the central chemoreceptors. So the person will do hyperventilation. A person, even if you stimulate the peripheral chemoreceptors or central chemoreceptors, doesn't matter. Okay, if you stimulate these chemoreceptors, the person is going to do the hyperventilation. But whenever there is alkalosis in the body, that alkalosis is going to inhibit. Okay, whenever there is alkalosis in the body, that alkalosis is going to inhibit the chemoreceptors. Okay, because acidosis is a stimulus for central chemoreceptors as well as to a degree peripheral chemoreceptors. So whenever there is alkalosis, this is not acidosis, guys. See, this is alkalosis. Now, because of the alkalosis, now the chemoreceptors are going to be inhibited. Whenever the chemoreceptors are inhibited, means, now tell me what happens. The ventilation, the hyperventilation will decrease. Okay. So now the patient is not going to do the hyperventilation. So hyperventilation decreases. Okay. Hyperventilation decreases. Now, is that good or bad? Tell me. Okay, is that good or bad? Tell me. Of course, this is not a good thing, because in high altitudes, to get the enough amount of oxygen, you have to do the hyperventilation. But what is happening? Because of the development of the respiratory alkalosis, already the patient is in alkalosis. Because whenever you are having alkalosis, the patient's respiratory rate decreases. Okay, so the person is not going to do the hyperventilation now, so hyperventilation decreases. So initially when you go to the high altitudes, this is MCQ. Initially when you go to the high altitudes, there's going to be hyperventilation. Later the ventilation rate decreases. But is that good? No, this is not good. So immediately what will happen is, see, this alkalosis is stopping. This alkalosis is stopping the ventilation. Okay, so now to balance this alkalosis, we are having certain counter-regulatory things like kidneys. What your kidneys are going to do? Kidneys are going to balance, okay, the pH. Now there is respiratory alkalosis. So now whenever there is alkalosis, this is not good. Your kidneys are going to start excreting bicarbonates. Okay, your kidneys will start to excrete the bicarbonates. So you are losing the bicarbonates in urine. Okay, so when you are losing the bicarbonates in the urine, see, again what is happening? The respiratory alkalosis is coming down. It's coming to normal. The respiratory alkalosis is coming to normal. Actually, your kidney excrete more bicarbonates, even more bicarbonates than required. More and more bicarbonates are going out through the urine. So look here, what happens is, now let's say here is the plasma. Okay, here is the plasma, here is the CSF, let's say here is the CSF. Now, from your plasma, the bicarbonates are being excreted, HCO3 minus, they are getting excreted, they are kicked out of the body. Okay, more and more bicarbonates are getting kicked out. So, now the bicarbonates, whatever were there in the cerebrospinal fluid, now these bicarbonates will be taken into the plasma. So now these bicarbonates ultimately are going out of the body. The bicarbonates are going out of the body. As the bicarbonates are going out, so what happened to the relative H plus concentration in the CSF? The H plus concentration increases. Now the H plus concentration is increasing because you are removing the bicarbonates. Actually, there is a balance as you are removing the bicarbonates. Okay, so these bicarbonates are going out of the body. So there is a relative H plus concentration increases, the relative H plus concentration increases. Now see, now this H plus, these are the acids, what they will do? They will stimulate. They will stimulate what? Chemoreceptors. Which chemoreceptors? Now it's a CSF, right? So it's the central chemoreceptors. Now the central chemoreceptors, they will be stimulated. Now you know, once the chemoreceptors, when they are stimulated, they are going to increase the ventilation. Now again, the person is going to do the hyperventilation. Again, the person is going to do the hyperventilation. So the points which I want you to know, guys, look, initially, what happened? Initially, see, when you go to the high altitudes, let's just highlight here important points. Now, when you go to the high altitudes, there is hypoxia, okay, that's going to stimulate the peripheral chemoreceptors. When the peripheral chemoreceptors are stimulated, means you are going to do the hyperventilation. Initially, there is hyperventilation, okay, but whenever you do the hyperventilation, there will be more carbon dioxide washout. So the acid levels in your plasma will decrease. So that is going to cause the respiratory alkalosis. Now, this respiratory alkalosis is an inhibitor of chemoreceptors. So alkalosis is inhibiting the chemoreceptors. So what happens to the ventilation? Ventilation comes down. There is no hyperventilation now. So initially there is hyperventilation. Later the ventilation decreases. Okay. Now what happens is the patient ultimately had this alkalosis, respiratory alkalosis. Now your kidneys are trying to compensate because you know there are buffer systems, buffers, lungs and kidneys. Buffers, lungs and kidneys, they maintain the pH. So whenever the patient is having alkalosis, your kidneys are trying to balance the pH by excreting. bicarbonates, because bicarbonates are the bases, they are alkali. So the alkali is getting excreted, bases are getting excreted. As you excrete the bases, what happened to the H plus concentration? The relative H plus concentration increases. Now that is acidosis. Relative H plus concentration increases means acidosis. Now that acidosis is going to stimulate the chemoreceptors. Once the chemoreceptors are activated means again there will be hyperventilation. Now this patient is going to have hyperventilation again. So if you look at the graph, okay, if you look at the graph, initially the person when he goes to the high altitudes, his ventilation increased. Okay, now here I am talking about the ventilation. Here I am talking about the time period. Okay, time and ventilation. Initially, ventilation increases. Later, ventilation decreases because of the respiratory alkalosis. Ventilation decreases. Okay, ventilation is decreasing. Now your kidneys will come and excrete the bicarbonates. It takes time. Okay, it takes time. Okay, 2 to 3 days. It takes time. Now later what happens, as you have excreted the bicarbonates, the relative H plus concentration increases. Again later the ventilation increases and that's going to be constant. Okay, ventilation increases and that's going to be constant. Okay, that's going to last for long duration. So these are some important points which I want you to know. Okay, so initially increases, later decreases and again it is going to increase. Okay, now what other effects that will be seen in the body because of this high altitudes? See, the patient is having alkalosis, right? Okay, the patient is having alkalosis. Look carefully. Now, whenever there is alkalosis, okay, whenever there is alkalosis, the patient, okay, in this alkalosis, in the RBC, okay, in the RBC, the patient is going to produce a something called as 1,3, okay, not 1,3, 1,2 bisphosphoglycerate. Okay, not 1,2, it's 2,3. Okay, sorry. In the RBC, the person is going to produce 2,3 bisphosphoglycerate. 2,3 bisphosphoglycerate. So what is happening during alkalosis condition? Okay, during alkalosis condition, the person is going to produce this 2,3 bisphosphoglycerate. What is this 2,3 bisphosphoglycerate doing? The 2,3 bisphosphoglycerate, it changes the nature of the hemoglobin. Okay, it alters the hemoglobin structure in such a way, it delivers more oxygen to the tissues. See, imagine I am the hemoglobin. Okay, I am the hemoglobin. I am carrying 4 molecules of oxygen. I am carrying 4 molecules of oxygen. Usually I deliver 1 molecule of oxygen to the tissues. Okay, every time I deliver 1 molecule of oxygen to the tissues, still I am carrying 3 molecules of oxygen. I am 75% saturated. Okay, even in the venous blood, remember, even in the venous blood, hemoglobin is carrying 3 molecules of oxygen. It's 75% saturated. But now, what is happening? See, whenever there is alkalosis in the body, this alkalosis is going to stimulate the production of the 2,3 bisphosphoglycerate. Okay, so whenever there is 2,3 bisphosphoglycerate, 2,3 BBG, that's going to cause a right shift in oxygen hemoglobin association dissociation curve. Okay, in the oxygen hemoglobin association dissociation curve, there will be a right shift because of the production of this 2,3 bisphosphoglycerate. Now what happens? Now hemoglobin delivers more oxygen to tissues. Okay, hemoglobin is going to do what? Now in the presence of this molecule 2,3 bisphosphoglycerate, now hemoglobin is going to deliver more molecules of oxygen. Instead of 1 molecule, it will now deliver 2 molecules of oxygen to the tissues because tissues require oxygen. Now tissues require oxygen. Okay, now tell me, if someone asks you alkalosis, okay, now the patient is having hypoxia. Okay, during hypoxia there is development of alkalosis. Alkalosis is going to produce 2,3 bisphosphoglycerate and there will be right shift. Actually, in the alkalosis condition, if you say, in the alkalosis condition, okay, the person is also going to have left shift. Okay, right shift and left shift. I have explained about the right shift. Right shift means more oxygen will be delivered. Okay, in the alkalosis condition, actually left shift will occur. To be very frank, this left shift is the more thing. Okay, during alkalosis, whenever there is alkalosis, left shift will occur. Okay, left shift will occur. But important point which I want you to know is, this left shift, okay, whatever this is happened, left shift, that's going to be show very little effect. Okay, so alkalosis is going to cause the left shift. It's going to be a minor effect. But whenever there is hypoxia, to be very frank, I should write something like this. Okay, hypoxia is going to stimulate the production of 2,3-bisphosphoglycerate. Rather than saying alkalosis, hypoxia, whenever there is hypoxia in your body, hypoxia is going to stimulate the production of 2,3-bisphosphoglycerate. That 2,3-bisphosphoglycerate is causing the right shift. And alkalosis is going to cause the left shift. Okay, alkalosis is going to cause the left shift. But who is more prominent? This right shift is more prominent. So more oxygen will be delivered to the tissues. Okay, so tell me, whenever there is respiratory alkalosis, there is left shift. Left shift means less oxygen will be delivered to the tissues. Less O2 deliver to tissues. Okay, less oxygen is getting delivered to the tissues. But what is the final effect? What is the final effect? Say, now there is more potent stimulator, more powerful inducer is there. That's the hypoxia. Hypoxia produces the 2,3-bisphosphoglycerate in the RBCs. That's going to cause the right shift. Whenever there is a right shift, okay, more oxygen will be delivered to the tissues. Hemoglobin deliver more oxygen to tissues. Okay, this is the point which I want you to know. Next, what else? Whenever there is hypoxia, I have explained you where hypoxia is going to stimulate 2,3-bisphosphoglycerate production. Hypoxia is also going to stimulate erythropoietin. I have explained you what this erythropoietin is going to do. Erythropoietin, the name itself is that it increases the number of RBCs. How? MCQ is erythropoietin stimulates certain stem cells. What are they? Colony forming units, erythroid colony forming unit. So MCQ, erythropoietin hormone stimulates colony forming unit, erythroid colony forming unit. So from this erythroid colony forming unit, you will have the RBCs. This RBC production takes days, okay, 5 to 6 days, even a week. So it's not going to be immediate thing. See, the production of erythropoietin is going to be immediate thing. It happens in hours. It happens in hours. Okay, within just hours, 2 hours or 3 hours, it happens. Whenever there is hypoxia in your body, immediately erythropoietin is going to be produced, but the production of RBCs takes days. Okay. Not only that, your hypoxia, what else it is doing? Whenever there is hypoxia in the high altitudes, this hypoxia is also going to stimulate your sympathetic centers, the vasomotor center. The vasomotor center in your rostral ventrolateral medulla. Okay, the rostral ventrolateral medulla, which is the sympathetic center. Okay, which is the sympathetic highest center, the rostral ventrolateral medulla. This will be stimulated because of the hypoxia. Whenever your sympathetic centers, sympathetic nervous system, when your sympathetic centers are stimulated, they do what? They increases your heart rate. They increases your cardiac output. The cardiac output will be increased. The heart rate will be increased. So now, look here carefully. The patient who is living in the high altitudes, okay, he is going to have hypoxia. Because of the hypoxia, erythropoietin levels will be more in his body. More colony forming units are getting stimulated. So ultimately, RBC count will be more. His vasomotor center will be active. Sympathetic nervous system is going to be active, so that increases the heart rate. So a person who is living in a high altitude will have more heart rate, more cardiac output. So more blood is going to the lungs to get the oxygen. Okay. So these are the points which I want you to know. Next, what is the effect of this hypoxia on your blood vessels, on your vasculature? Okay, effect of hypoxia on the vasculature. Guys, look, there are actually two types of vasculature in your body. Okay, one is pulmonary vasculature and systemic vasculature. Okay, systemic blood vessels as well as the pulmonary blood vessels. See, they respond differently. Okay, they respond differently. See, whenever there is hypoxia in the pulmonary system, in the lungs, okay, first of all, why blood is going to the lungs? Tell me, why blood is going to the lungs? For the purpose of oxygenation. For the purpose of oxygenation ke liye. See, whenever there is hypoxia in the lungs, in certain area, for example, let's say, see, this is your lung. Now, in this area, there is very less oxygen. For example, let's say there is very less oxygen. In this area, there is hypoxia. Now, the blood flow to this area is going to decrease. The blood vessels will undergo vasoconstriction because oxygen availability in that area is not there. So, now the blood will be diverted to the area where more oxygen is available. You know, in your lung, there is apex, there is middle lobes, there is a base. So, in the apex, there will be the oxygen availability will be less. In the base, there will be more oxygen availability. You know, right? The oxygen distribution in your lungs is also different. So, now what happens is, in the pulmonary vasculature, wherever there is hypoxia, there will be vasoconstriction. So, remember one point. So, how the pulmonary blood vessels are going to respond? Pulmonary blood vessels will undergo vasoconstriction. Direct MCQ. Pulmonary blood vessels. Okay, pulmonary blood vessels will undergo vasoconstriction. That too, it's called as a patchy. Okay, patchy vasoconstriction. Okay, certain areas are also undergoing like vasoconstriction, certain areas not. Okay, there will be patchy vasoconstriction. But now let's talk about the systemic vasculature, systemic blood vessels. Now tell me, your tissues are getting hypoxia. They are not getting enough amount of oxygen. Okay, they are not getting enough amount of oxygen. So you have to send more blood to the tissues so that more oxygen will go to the tissues. Okay, you have to send more blood to the tissues. You have to increase the blood flow to the tissues. That's why the capillary density increase, the cardiac output increase, the heart rate increase. So systemic vasculature, how it responds is by doing vasodilation. Okay, so there will be systemic vasodilation. See the mechanism, how the in detail mechanism I am not going to details. There will be vasodilation in the systemic blood vessels and vasoconstriction in the pulmonary blood vessels. Okay, these are the points which I want you to know. So finally, let's see what are the changes that will be seen. Hypoxia is going to cause vasoconstriction of pulmonary blood vessels, vasodilation of the systemic blood vessels. Okay, hypoxia, whenever there is hypoxia, the person's vasomotor center which is present in the medulla. Okay, so rostroventral medulla, that will be active. So that activates the sympathetic centers. So sympathetic nervous system is going to increase the heart rate, increase the cardiac output, and increases the BP of the patient. Okay, in high altitude, all these things will be seen. Okay. Next, whenever there is hypoxia, the erythropoietin production is going to be more, which stimulates the erythroid colony forming units, which further increases the RBC count within a week. Next, whenever the person is having alkalosis, see, when you are living in the high altitudes, yes, of course, you develop the alkalosis. Okay, you develop the alkalosis. Whenever there is alkalosis, actually there is left shift. Okay, actually there is left shift. But this left shift, the effect of the left shift will be dominated by the 2,3-bisphosphoglycerate. This 2,3-bisphosphoglycerate is going to cause the right shift. Okay, so actually this is two different things. Alkalosis is going to cause left shift. 2,3-bisphosphoglycerate is going to cause right shift. Right shift is good. It delivers more oxygen to the tissues. So in high altitudes, yes, of course, alkalosis is there. Left shift will occur, but that's going to be minor. It's not going to be permanent. Okay, so hypoxia is going to induce the 2,3-bisphosphoglycerate, that causes the right shift. So more oxygen delivered will be to the tissues. More oxygen will be delivered to the tissues. So finally tell, if there is hypoxia, there will be right shift. Hypoxia is going to cause right shift. Next, if you are living in high altitudes, initially your ventilation, okay, initially your ventilation is going to be more. There will be more ventilation, hyperventilation. Later, that ventilation is going to decrease. Okay, because of the respiratory alkalosis, you know, because of the respiratory alkalosis, alkalosis is an inhibitor of chemoreceptors. When the chemoreceptors are inhibited, ventilation comes down. Okay, ventilation decreases. Next, what happens? Immediately, kidneys will excrete the bicarbonates. Kidneys will excrete the bicarbonates. As you are excreting the bicarbonates, again acidosis will develop in the body. That acidosis is going to again causes the hyperventilation. The initial increase, later decrease, and again increase and constant. So the patient is going to be on hyperventilation. Hyperventilation. Now, when compared to a normal person, okay, in these patients who are living in high altitudes, they are having how much percent extra? Okay, they are going to have 65% extra hyperventilation, more. Okay, 65% increase in the ventilation. Okay, so these are the points which I want you to know. Okay, next, these are something normal. Okay, what and all I have discussed, all these are normal. See, living in high altitudes may cause, okay, living in high altitudes may cause some adverse pathologies. Okay, adverse pathologies. What are they? If you are living in a high altitude, the patients will develop 3 problems. Let me write here itself: acute, mountain, sickness. Okay, acute mountain sickness. The patient is having acute mountain sickness. Okay, when you ascend rapidly to the mountains, you will get acute mountain sickness. Next, high altitude cerebral edema. Next, high altitude pulmonary edema. See, these are the three problems, okay, one can get with high altitude. Okay, now what exactly, say this acute mountain sickness, simple. Okay, acute mountain sickness actually develops in the first 24 hours. Okay, in the first 24 hours, you are going to have the acute mountain sickness where the person is going to have severe headaches. Okay, where the person is having severe headache, nausea, vomiting. Okay, these symptoms, severe headache, nausea and vomiting. Okay, now why it occurs is, let me tell you why it occurs is, I have told you this patient, okay, the patient is having systemic vasodilation. Okay, the patient is having systemic vasodilation, so more blood is going to the tissues, more blood is going to his cerebral vasculature, the more blood is going to his brain. That more blood which is going to brain is going to cause, it's going to start the cerebral edema. Okay, actually this is a milder condition. Okay, it's a milder condition. The more severe variant is high altitude cerebral edema. It's going to be severe. Okay, it's going to be severe. Initially, like that edema, it's going to be little, so you're going to have little headache, nausea, like you are not going to get the sleep. Okay, altered sleep patterns. Okay, so these are the symptoms which are going to be seen in acute mountain sickness. But if it is more severe, okay, it takes days. If it's more severe, these patients are going to have the mental changes. Okay, the person is going to behave differently. Okay, mental changes will be seen, and he's going to lose the balance. Okay, so gait or balance. Okay, or ataxia. So these are the features of high altitude cerebral edema, because there is more blood flow going to the cerebral vasculature, and that more blood flow is going to cause the edema. Okay, so where exactly is this edema is going to occur? This edema is going to occur in which part of the brain? It is corpus callosum. In the corpus callosum area, there will be edema. Okay, corpus callosum area, there will be edema, and that's going to cause the symptoms, nausea, vomiting. Okay, alteration in the mental status, gait abnormalities will be seen. Okay, now for this diseases, okay, acute mountain sickness, high altitude cerebral edema, what you have to do? What you have to do is the treatment. Okay, let me write here, acute mountain sickness, it's a milder form, and high altitude cerebral edema, the treatment is done with, okay, the treatment is done with oxygen, hyperbaric oxygen. Okay, all this problem is because of the oxygen, right? So hyperbaric oxygen. Okay, you are going to give the hyperbaric oxygen, means oxygen with more pressure. Next, what else you can do is dexamethasone. Okay, so dexamethasone can be used in these patients. Okay, dexamethasone, hyperbaric oxygen, and you have to immediately descend this patient down to the lower level, so towards the sea level. Okay, rapid descent. Okay, bring him down. So these are the things what you can do for the acute mountain sickness or high altitude cerebral edema. You can also use acetazolamide. Okay, acetazolamide for mountain sickness. Why? Because acetazolamide, whenever you go to the high altitudes, that mountain sickness will be there. These patients are going to develop the respiratory alkalosis. Okay, respiratory alkalosis. This acetazolamide is a carbonic anhydrase inhibitor. Okay, it's a carbonic anhydrase inhibitor which acts on the PCT. It causes bicarbonate urea. Okay, it causes the bicarbonate excretion out of the body. Okay, so that respiratory alkalosis can be better treated. So acetazolamide is used for mountain sickness. True. Okay, mountain sickness. So acetazolamide, dexamethasone, rapid descent of this person, and hyperbaric oxygen, they can be given. Next, for high altitude pulmonary edema. What exactly is this high altitude pulmonary edema? What exactly is this? Look, now in the high altitudes, okay, in the high altitudes, what is happening? There is systemic vasodilation, but pulmonary vasoconstriction. Pulmonary vasoconstriction. Okay, so in certain areas of the lung, for example, say here, now the blood vessel is going like this, Now, these blood vessels, these blood vessels are going to be dividing, let's say something like this. So there is patchy vasoconstriction, right? Let's say something like this. Now, certain blood vessels are going to be constricted. When the certain blood vessels are constricted, now look, the blood which was supposed to go in this direction, now blood is going into the other blood vessels. Already in these patients there is high heart rate is going to be more, cardiac output is going to be more, BP is going to be more, all these are high. So more blood is going to the lungs, but certain blood vessels are constricted. There is patchy constriction, not diffuse constriction. There is patchy constriction of the blood vessels, because of which now more and more blood is going into these blood vessels. And whenever there is more and more blood, you tell me, that's going to cause a damage of these blood vessels. That immensely increases the hydrostatic pressure in these blood vessels. So now what happens is, now the blood or the fluid is going to leak into the lung, leading to edema. Okay, so now there is a damage to this pulmonary vasculature. There is increased hydrostatic pressure in these capillaries. Whenever the hydrostatic pressure is increased, what happens? More and more fluid, more and more plasma will leak into the lung, will leak into the alveolus. So that's going to cause this edema. Okay, that's going to cause edema. That is called as high altitude pulmonary edema. All this is because of the patchy pulmonary vasoconstriction. So tell me, all this problem is because of this vasoconstriction. So what you have to do? You have to relax these blood vessels. Okay, so we are going to give the calcium channel blockers, because calcium is required for the smooth muscle. The calcium is required for the smooth muscles to contract. Okay, calcium is required for the smooth muscle to contract, so that blood vessels will undergo constriction. So now what you are using? You are using calcium channel blockers like nifedipine. Okay, nifedipine. So nifedipine is the drug. Okay, super important drug which will be used for the treatment of high altitude pulmonary edema. Nifedipine MCQ. So also to this person, you can use hyperbaric oxygen. Okay, hyperbaric oxygen supplementation, and rapid descent. Okay, you can give. Okay, so nifedipine is given for this high altitude pulmonary edema. So with this, the pathologies which will be seen in the high altitudes, that is the acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema, their problems and their treatments also I have discussed. Not only this, some miscellaneous things which I want you to know. Whenever you go to high altitudes, not only you are going to have just hyperventilation, okay, hypoxia, not only you are going to get the hypoxia. Let me write some more few things. Let's say, here the person not only going to have this one problem, hypoxia, this patient is also going to get cold. He is going to get hypothermia. Okay, he is going to get the hypothermia. Not only this, the patient is going to get dehydrated, because there will be more water loss, more fluid loss. Okay, whenever such a cold environment is there, you are breathing more number of times. You are breathing more number of times. You are doing the hyperventilation. So you know, with every breath, some amount of water vapor is going out. You can't feel it. You don't know it. But some water is always leaving. Okay. See, just take a glass and just try to do like this. Something like this. You are going to form a vapor over there, which means some water is going. Every day we lose the water. Living in high altitudes, you are doing more number of breathing, you are doing more times breathing, so more fluid will be lost. Almost 4 or 5 liters of like water will be lost out of the body. So these patients are going to have more fluid loss, true, living in high altitudes. They will develop hypoxia, true, and the body temperature is also going to decrease. There will be hypothermia. Okay, so these are the points which I want you to know in the topic of high altitude physiology. Hope the video is helpful. Thank you.